Most people walk into a surgeon's office carrying one fundamental belief, that if a doctor is recommending an operation, then that operation must be the right path forward. The physician is trained. The facility has everything needed. The forms are already prepared. Just put your signature here and we will take care of the rest. I carried that same belief myself until the day I began paying close attention. Paying attention to the patients who entered those operating rooms for what were described as routine procedures and emerged on the other side permanently altered, not healed, not improved, altered in ways nobody had prepared them for. A gentleman who walked through the hospital entrance with chronic back pain and was carried out in a wheelchair, unable to move his legs the way he once could. A woman who survived an open chest procedure but surrendered 6 months of her remaining life to a cascade of complications that no one had taken the time to explain to her in advance. Here is the truth that most people sitting in those consultation chairs never hear. The older your body becomes, the harder it must work simply to endure the experience of surgery itself. Not the illness, not the condition that brought you there. The surgery itself becomes its own battle. I am a cardiothoracic surgeon with more than 20 years of direct experience inside operating rooms. And what I am going to share with you today is the honest, unfiltered truth about 5 specific surgical procedures that carry genuinely serious and frequently hidden risks for anyone over the age of 60. Let me offer you an analogy that I find captures this perfectly. If you place a brand new vehicle and one that has accumulated 200,000 miles on the road side by side and run them both through an identical stress test, you do not expect identical results. The logic is self-evident. And yet, for the better part of several decades, the medical profession approached a 70-year-old human body with the exact same surgical protocols, the same recovery timelines, and the same performance expectations it applied to a 40-year-old one. That approach is beginning to shift, but not at anywhere near the pace that patients deserve. Let me walk you through what actually happens inside an older body the moment it goes under general anesthesia. The heart is required to labor harder than it would under normal circumstances. The lungs require significantly more time to clear the anesthetic agents from their tissue. The kidneys slow considerably in how they process and eliminate medications. And the brain, and this is the piece that consistently catches people completely off guard, the brain enters a state of temporary disorientation that in some patients persists not for hours, but for weeks, sometimes months. The clinical term for this condition is post-operative cognitive dysfunction. In patients who are over 70 years of age, it occurs far more frequently than the medical community openly acknowledges. Now, before we go any further, I want to make one thing absolutely and unambiguously clear. Age by itself is not a reason to decline surgery. I have personally operated on patients in their 80s who recovered with a speed and resilience that would put many 50-year-olds to shame. Age is a number, but frailty is something entirely different. Frailty is a precise medical term. It describes a condition in which the body's physiological reserve has declined below a critical functional threshold. Approximately 40% of individuals over the age of 75 show measurable signs of frailty. That figure climbs to nearly 60% in those over 85. So the real question, the one that matters far more than most patients ever realize, is not whether a person can survive the operation on the table. The question is whether that person can survive the recovery that follows, because those are 2 fundamentally different challenges. And that distinction is going to carry enormous weight in everything we are about to discuss. Surgery. Number 1. Open heart surgery in frail patients. Coronary artery bypass grafting, referred to in surgical circles as KBG, ranks among the most frequently performed major operations on older adults. The premise is medically straightforward. Your coronary arteries are blocked or severely narrowed. We redirect the blood flow around those obstructions. And for the patient who is the right candidate, the results can be genuinely transformative. But here is what never appears in the informational brochures sitting in the waiting room. Open heart surgery requires your heart to be stopped completely. You are placed on a cardiopulmonary bypass machine, an external device that assumes the function of both your heart and your lungs for the duration of the procedure. For a 60-year-old patient in solid overall health, that is a manageable physiological experience. For a 78-year-old who is simultaneously managing kidney disease, early-stage diabetes, and some degree of cognitive decline, that same bypass machine represents a simultaneous assault on every major organ system in the body. Published research consistently shows that in frail elderly patients, open heart surgery carries a 30 to 40% probability of serious major complications: stroke, acute kidney failure, prolonged mental confusion, and extended dependence on mechanical ventilation. And here is the figure that stops people cold when they hear it for the first time. Up to 15% of high-risk elderly patients do not survive the first 30 days following this surgery. Not from the condition that brought them there, from the operation itself. So what alternatives exist? In a growing number of clinical situations today, there is one that deserves serious consideration. It is called TAVI, transcatheter aortic valve implantation. It is a catheter-guided intervention that accomplishes its goal without ever stopping the heart or requiring the chest to be opened. It is far less dramatic in appearance than traditional open surgery, but it is infinitely kinder to a body that requires kindness rather than confrontation. Does this mean every elderly patient should categorically refuse heart surgery? Absolutely not. It means every elderly patient should walk into that consultation and ask one specific question: am I a candidate for a less invasive approach? That single question, asked with confidence, has the potential to change the entire direction of the conversation. Surgery number 2, aggressive spinal surgery. Back pain in a person's 60s and 70s is essentially universal. In all my years of practice, I cannot recall a single patient over 70 who has not mentioned their spine at some point in our conversations. And the solution being offered with increasing frequency is spinal surgery: multi-level fusions, complex decompressions, metal hardware implanted at multiple points up and down the vertebral column. I want you to hear this with complete clarity. There are absolutely situations in which spinal surgery is not only appropriate, but urgently necessary. When the spinal cord is being actively compressed to the point of causing loss of bladder function or advancing paralysis, surgical intervention cannot wait. That is a genuine emergency. But elective spinal fusion surgery for the management of chronic back pain in elderly patients, that is where the evidence becomes genuinely and deeply troubling. A major investigation published in the journal Spine found that in patients over 65 years of age, complex spinal fusion carried a complication rate that exceeded 40%. 40%. And the complications that appeared most frequently were not minor inconveniences. They included deep vein blood clots, serious infections, hardware failure, and a condition called adjacent segment disease, a process in which the vertebral segments immediately above and below the fused section begin to deteriorate, because the mechanical burden that would normally be distributed across the entire spine is now being concentrated on those neighboring structures. One section is held rigidly in place, and the remainder absorbs the consequences. But here is the aspect of this that frustrates me most deeply: the pain relief outcomes. Studies examining long-term results in elderly patients with degenerative spinal disease show that aggressive surgical intervention provides no meaningfully superior relief from pain when compared to a structured program of physical therapy combined with targeted injections. No better outcomes, but with dramatically and disproportionately elevated risk. A colleague of mine, an exceptionally skilled spine surgeon, said something to me years ago that I have never stopped thinking about. He said, "Sometimes the best operation is the one that never happens." I return to those words regularly. Have you personally been told that surgery was your only remaining option for back pain? Write that in the comments below. I genuinely want to understand how many people watching this have been handed exactly those words. Surgery number 3, major cancer resections. This is the most emotionally difficult territory on this entire list to navigate honestly, because the moment a person hears the word cancer, everything in them responds with one singular overwhelming impulse: remove it, eliminate it, take it out of my body immediately. And I understand that response at the deepest possible level. I would feel it myself. But here is what more than 2 decades of surgical experience has made unmistakably clear to me. The objective of cancer treatment is not simply the physical removal of a tumor. The objective is to provide the patient with more years of meaningful, high-quality life. And sometimes, not always, but sometimes in ways that matter enormously, major surgery performed on a frail elderly patient achieves the precise opposite of that goal. Let me be specific. Pancreatic cancer surgery, the procedure known as the Whipple operation, stands among the most technically demanding and physiologically demanding operations in the entire field of medicine. It involves removing the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the bile duct. The operation itself occupies 6 to 10 hours in the operating room. In younger patients with robust overall health, it represents a genuine opportunity to extend life. In an 80-year-old patient carrying concurrent heart disease and diminished kidney function, the surgery may be executed with complete technical success. The tumor is removed, the margins are clear, and the patient may still be gone within weeks, taken not by the cancer, but by the physiological devastation of the operation. This is what surgeons call futile surgery, and it occurs with a frequency that the medical community is deeply reluctant to discuss openly. A landmark analysis conducted by the American College of Surgeons revealed that nearly 1 in 5 elderly cancer patients who underwent major resective surgery experienced what researchers termed failure to rescue, meaning that a serious complication arose that the patient's weakened and already strained body was simply no longer capable of overcoming. So what is the conversation most worth pursuing in these situations? Ask your oncologist directly and without hesitation. If we were to forego surgery, what would watchful waiting look like for someone with my age, my health history, and my current functional status? What would radiation achieve? What would targeted therapy offer? That question opens a doorway that many patients never discover exists. And sometimes, the path that lies beyond that doorway leads to a genuinely better outcome. Surgery. Number 4. Elective joint replacement in severely ill patients. Hip and knee replacement surgery represents one of the most consistently successful categories of surgical intervention ever developed in modern medicine. I state that without any qualification. For the patient who is the right candidate at the right moment, a new hip joint can utterly transform daily existence. People transition from barely being able to cross a room to getting down on the floor with their grandchildren. The results, when conditions are aligned, are remarkable. But this is precisely where it becomes complicated for older adults carrying multiple concurrent health conditions. The word elective carries a meaning that patients sometimes underestimate. It means the surgery is scheduled and planned rather than emergency-driven. You have time. Time to reflect, time to prepare, and, most critically, time to evaluate whether this particular moment in your health history is the right moment for your specific body. Because the statistics paint a picture that deserves careful attention. In patients over the age of 75 who are simultaneously managing 3 or more serious chronic conditions, cardiovascular disease, type 2 diabetes, chronic kidney disease, or significant obesity, elective joint replacement carries substantially elevated risk of serious perioperative complications. The most significant danger is blood clot formation, deep vein thrombosis, in which clots develop within the deep veins of the legs, can migrate to the lungs, and become a life-threatening pulmonary embolism. In elderly patients with already compromised circulation, this risk is measurably and significantly higher than in younger surgical candidates. Layer onto that the risk of post-operative pneumonia arising from extended periods of limited mobility. Add hospital-acquired infections. Add the physiological stress of anesthesia on a body managing multiple conditions simultaneously. The picture becomes considerably more complex than the standard pre-surgery consultation typically conveys. I want to be precise here because the last thing I intend is to frighten anyone away from a surgery that could genuinely restore their quality of life. The question is not whether you should ever have a joint replacement. The question is whether your body is in the strongest possible condition right now to handle it and recover from it successfully. Systematically optimizing blood pressure, blood glucose levels, body weight, and cardiovascular function before elective surgery has been demonstrated to reduce complication rates substantially. Some of the most forward-thinking hospitals now require patients to complete a formal prehabilitation program before an elective joint replacement will even be scheduled. and that is precisely the correct approach to protecting elderly patients. Has your physician ever discussed prehabilitation with you in advance of a planned procedure? Most people watching this have never encountered that word. They absolutely should. Surgery number 5. Emergency abdominal surgery. I need to acknowledge something important before discussing this final surgery, because it is categorically different from everything that preceded it on this list. You do not choose emergency abdominal surgery. The circumstances choose it for you. A perforated bowel, a ruptured appendix, uncontrolled internal hemorrhage. These are situations that do not permit calm deliberation in a physician's office. They arrive without warning, and they demand an immediate response. But here is precisely why this belongs on this list. Understanding the risks associated with this type of surgery before an emergency occurs changes how patients and their families navigate the devastating decisions that must be made in those terrifying, disorienting moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates recorded anywhere in the field of surgery. We are discussing figures between 30 and 50% in the most severe presentations, and this is not a reflection of surgical skill or institutional quality. It reflects the reality of what happens when an elderly body is suddenly subjected to severe physiological trauma. The liver, the kidneys, the heart, and the lungs are all impacted simultaneously. And the systemic inflammatory response that a younger body typically brings under control within a matter of days can escalate in an older body into a condition called systemic inflammatory response syndrome, a cascading shutdown of multiple organ systems in sequence. It is as medically serious as it sounds. So what can you practically and meaningfully do with this knowledge? 2 things. First, do not minimize or delay evaluation of abdominal symptoms. Persistent pain, unexplained bloating, significant changes in bowel habits in anyone over 60 deserve prompt and thorough medical investigation. Identifying and addressing problems in their early stages means treating them through manageable interventions before they deteriorate into emergencies. That single commitment to attentiveness can change everything. Second, have the difficult conversation with your family now, not in a hospital corridor at midnight, surrounded by strangers and fluorescent lighting and fear. Now, in the comfort and clarity of your own home. What are your wishes if emergency surgery becomes the only available option? What elements of quality of life hold the most meaning for you? What are the limits of intervention you would want respected? These conversations are not morbid. They are not defeatist. They are among the most profoundly loving and responsible things you can offer to the people who will one day be standing in that corridor trying to make impossible decisions on your behalf. What you do with this knowledge. We have now examined 5 surgeries in full, and the most important thing I can offer you now is not more information. It is a framework for action, because information that leads nowhere is simply a source of anxiety, and generating anxiety in the people watching this is the very last thing I want to accomplish. Before any major surgery, whether planned in advance or recommended unexpectedly, there are 4 questions that every patient over 60 should be prepared to ask. Write these down. Question 1. What is the realistic outcome if I choose not to have this surgery? A surgeon who is being genuinely honest with you will give you a direct, substantive answer. If the answer indicates that nothing will change urgently in the next 6 to 12 months, you have time. Time to reflect carefully. Time to pursue a second opinion. And time to work on improving your health profile before making a final decision. Question 2. Does a less invasive alternative exist for my specific condition? Medicine has advanced at a remarkable pace over the past 15 years. Robotic surgical systems, endoscopic techniques, catheter-guided interventions, options that were entirely unavailable a decade ago are now accessible in the majority of major medical centers. Ask about them directly and specifically. Question 3. What does a realistic recovery look like for someone with my precise age, my particular health conditions, and my current life circumstances? Not for the average patient in a published study. For you, your heart function, your kidney capacity, your current medications, and the environment you will be returning home to. The answer you receive should be specific and individualized, not general and reassuring. And question 4. This is the one that most patients never think to ask, and it may be the most revealing of all. What is your personal complication rate for this specific procedure in patients over the age of 70? Surgeons track this data. They know their own numbers. A surgeon who is both skilled and honest will answer that question without hesitation or defensiveness. If the question seems to make them uncomfortable, if there is a pause, a deflection, a change of subject, that response in itself is a piece of information worth taking seriously. Before I reach the most important point I want to leave you with today, let me offer you something that I genuinely hope you carry with you. This video is not constructed around fear, it is constructed around options, and the options available to elderly patients today have never in the history of medicine been more varied, more effective, or more worthy of serious consideration. Minimally invasive surgery has fundamentally transformed what is achievable for older patients. Laparoscopic approaches involving small incisions and camera-guided precision dramatically compress recovery time. Robotic-assisted procedures provide a level of accuracy and control that exceeds what human hands alone can consistently achieve. And catheter-guided cardiac interventions have opened the door to treatment for patients who would never have been candidates for conventional surgery. Beyond the surgical realm itself, and this is something I genuinely wish more patients were told by more physicians, optimized medical management is far more powerful than it is typically given credit for being. The right combination of appropriately selected medications, supervised and progressive physical therapy, targeted injection therapies, and structured nutritional support can successfully manage a significant number of conditions that were previously assumed to require surgical intervention. The human body possesses a profound and persistent will to heal. Our responsibility as surgeons is sometimes simply to remove the obstacles and provide the conditions. I want to share one patient's story with you. I will call him Gerald, 71 years old, retired engineer, intellectually sharp, perceptive, and deeply engaged with everything happening around him. He came to me after 3 separate surgeons at 3 different institutions had each independently recommended open-heart surgery for a blocked coronary artery. 3 consultations, 3 surgeons, the same recommendation every time. Gerald was not afraid of the surgery itself. What frightened him was the possibility of losing himself in the process. He had watched his wife undergo a major operation 2 years before our meeting and had witnessed her emerge from it confused, profoundly fatigued, and in his words, never quite the same person she had been before. He sat across from me and said something I have never forgotten. He said, "She walked into that hospital as my wife. She came out as someone I needed to care for." That sentence has never left me. When I conducted a thorough review of Gerald's complete medical profile, his kidney function, his formal frailty assessment score, his cognitive baseline, I sat with him for 40 minutes, not the standard 15, 40. And I told him the truth as I understood it. Surgery was genuinely an option, but so was an aggressive and carefully structured medication protocol combined with a formal cardiac rehabilitation program. The published data for his specific health profile demonstrated comparable 5-year survival outcomes between the 2 approaches. Gerald chose the non-surgical path. That was 4 years ago. Last month, he sent me a photograph. He is standing at the summit of a hiking trail in the mountains of Colorado, flanked by his 2 granddaughters, both of them now taller than him, and wearing an expression that can only be described as a man who feels he won everything that matters. Here is what I need you to understand above everything else I have said today. This is the single most important sentence in this entire video. A surgical recommendation is not a verdict. It is an opening position in a conversation. You are not a passive recipient of decisions made about your body by people with credentials on the wall. You are an active, engaged, and fully empowered participant in your own healthcare. The moment you sit down across from a surgeon, you hold the right to ask every difficult question on your list, to request exploration of every alternative that might exist, and to take every single day that you need before arriving at a decision. The surgeon holds the instruments. You hold the choice. And that choice, made with complete information, with clear eyes, and without pressure, is the most powerful therapeutic tool that medicine has ever known. More powerful than any operation I have ever had the privilege to perform. Let us bring everything together. 5 surgeries carrying serious hidden risks for people over 60. Open heart surgery in frail patients. in an era where less invasive alternatives have become genuinely viable. Aggressive spinal fusion, where the evidence supporting meaningful long-term pain relief is far weaker than most patients are ever told. Major cancer resections, where the guiding objective must always remain more good years of meaningful life, not simply the technical removal of a tumor. Elective joint replacement in severely ill patients, where the timing of the procedure and the preparation preceding it matter as profoundly as the surgery itself. And emergency abdominal surgery, where the most powerful protection available is the early identification of warning signs and the honest, loving conversations held with family long before any emergency arrives. None of this is a call to avoid surgery. Surgery preserves life every single day. I have witnessed it. I have been part of it. I am genuinely proud of what can be accomplished in an operating room when the circumstances are right. The message is this: be an informed patient. Ask the hard questions without apology. Request the alternatives without embarrassment. Pursue a second opinion. And if necessary, pursue a third. Your age is not a liability. Your experience, your knowledge of your own body, and your willingness to advocate for yourself are among the most powerful assets you carry into any medical setting. What is the one question you would most want answered before undergoing a major operation? Tell me in the comments below. I read every response. And if this conversation has helped you or someone you care about think more clearly and more confidently about a surgical decision, please share it. That one act of sharing may turn out to be among the most meaningful things you do today. Take care of yourselves. Stay curious. Keep asking questions and keep advocating without reservation for your own health and well-being. You deserve a surgeon who explains everything fully and honestly. You deserve a medical team that treats you as an equal partner in every decision. And everything shared in this video represents general medical information grounded in published clinical research and direct professional experience. Every individual's situation is unique and irreplaceable. Before making any decision regarding surgery or medical treatment, please have a full, honest, and unhurried conversation with your own physician or specialist. They know your complete history. They know your body in ways that a video cannot. And that conversation, informed, direct, and conducted without anyone watching the clock, is exactly where genuinely good medicine begins.